Welcome to this high-yield revision deep dive tailored specifically for plastic surgery residents preparing for board exams like the FRCS.
Absolutely. If you are gearing up for the boards, you are in exactly the right place.
Before we jump into today's review, just take a second to hit that follow button so you never miss a revision session. And please rate the show if you find this material helpful for your prep.
It really helps.
It does. Also, for those of you looking to really take your studying to the next level, you need to get a premium subscription to access our exclusive Journal Club and Clinical Cases deep dives.
Those are incredibly high yield for the clinical scenarios you'll face.
Definitely. All right, we are not going to waste a single second today. Let's get straight to it. We are looking at the baseline pathology of lymphedema. To kick off this rapid-fire revision, let's define exactly what we are dealing with at a cellular and tissue level.
Right, because at its core, lymphedema is not just a simple fluid problem. It is the accumulation of protein-rich interstitial fluid.
Because capillary hydrostatic pressure is constantly forcing that proteinaceous fluid into the interstitium.
Exactly. The venular capillaries manage to reabsorb about 80 to 90% of that fluid, but the lymphatic system acts as the absolute crucial accessory route for that remaining 10 to 20%.
And that 10 to 20% is what makes all the difference, isn't it?
Oh, entirely. Once that interstitial fluid enters the lymphatic system, it officially becomes lymph. When the system fails, you don't just get a buildup of water, you get a stagnation of high protein fluid.
Which is incredibly toxic to the surrounding tissue over time.
It is. That stagnant, protein-rich environment triggers a cascade of severe clinical issues. It leads directly to chronic inflammation, then adipose tissue hypertrophy, and finally severe tissue fibrosis.
That triad.
Inflammation, fat proliferation, and fibrosis.
It's exactly what causes the disfiguring and function-limiting pathology you see in the clinic. So to really grasp that pathology for the exam, we have to look at the embryological origins and the normal anatomy. The crucial things residents need to recall here start with the origins. The entire lymphatic system, the vessels, the nodes, the spleen, it all derives from the mesoderm, right?
Yes, it essentially buds directly off the venous system. By the second month of gestation, you have these tiny lymph sacs beginning to bud from venous endothelial cells.
And those sacs eventually coalesce into primitive lymphatic capillaries, so you have a rudimentary network by the end of that second gestational month.
But the functional valves, which are just so critical to the system's mechanics, they don't actually appear until the 5th month of gestation.
The developmental timeline is fascinating, and anatomically, we break the fully formed system down into 3 distinct divisions.
Let's run through them. First, you have the superficial system, which is superficial. It lives entirely within the subcutaneous fatty tissue and drains the skin in those subcutaneous layers.
Then you have the deep system, which is subfacial. This deep network accompanies the major blood vessels and is responsible for draining the muscles, tendon sheaths, nerves, periosteum, and the joints.
And finally, there's the visceral system, which obviously drains the internal organs. The intestines, spleen, liver, thymus, and lungs.
There is a great trivia point for the boards here regarding the visceral system.
The milky lymph.
Exactly. Lymph from the intestine actually appears milky white because of the high concentration of fatty acids being absorbed directly from the gut.
Always a good one to remember.
So looking closer at the macroanatomy, how does fluid actually move through these vessels?
Well, the lymph capillaries originate out in the peripheries as these valveless, blind-ended tubes. They are significantly more permeable than regular blood capillaries because they completely lack a basement membrane.
Which allows those large protein molecules to actually get in.
Right. These highly permeable capillaries connect to precollectors, which then funnel the fluid into lymph collectors.
And these collectors are tiny, ranging from 0.1 to 0.6 millimeters in diameter. But they structurally resemble regular vascular structures.
They do. They have an intima, a media, and an adventitia. And this is where those valves we mentioned earlier come into play. Valves appear every 6 to 20 millimeters along the collector vessel.
And the specific segment between a pair of valves has a unique name you absolutely need to know for the boards.
The lymphangion.
The lymphangion. It is effectively the functional pumping unit of the system.
And all of those functional units eventually have to route that fluid back into the venous circulation through the major trunks.
So map those out for us.
Sure. The left and right lumbar trunks drain everything from the lower limbs, the lower trunk, and the external genitalia. Those lumbar trunks travel upward and join the gastrointestinal trunk to form the cisterna chyli.
A highly variable structure, but for the exam, you need to know its exact anatomical location.
Yes, it's a thin-walled sac located anterior to the vertebrae, anywhere from T11 down to L2.
From that sac, the thoracic duct runs cranially alongside the aorta. And the thoracic duct is the absolute heavyweight of the system.
It is the largest lymph trunk in the body. It can measure up to 5 millimeters in diameter.
And it pumps a staggering 3 liters of lymph per day into the venous system.
Specifically emptying into the junction of the left internal jugular and subclavian veins.
Protected by a terminal valve right at that junction to prevent any blood from refluxing back into the lymphatic system.
Meanwhile, the right side of the body is handled by the right lymphatic duct, which is much shorter, just 1.5 centimeters. That drains into the junction of the right internal jugular and subclavian veins.
Okay, so we have the normal anatomy mapped out. When that entire complex network breaks down, what is the exact pathogenic mechanism of lymphedema? And how do we classify the etiologies for the boards?
To understand the mechanism, you first have to rigorously differentiate simple edema from true lymphedema.
Simple edema just being the accumulation of low-protein fluid in the interstitium.
Exactly. The classic pitting edema you see in patients with cardiac insufficiency, prolonged immobility, hypoproteinemia, or even from medications like calcium channel blockers.
Lymphedema, conversely, is a high-protein edema resulting strictly from lymphatic insufficiency.
And that insufficiency is driven by two very distinct mechanical failures: high-volume insufficiency and low-volume insufficiency.
The physiological difference between those two is such a high-yield concept. Let's break it down.
In high-volume insufficiency, the lymphatic system is actually intact, but the lymphatic load simply exceeds its maximum transport capacity.
Think of it like a massive traffic jam that eventually destroys the road itself.
That's a great way to put it. It often begins as chronic simple edema. If that simple edema persists for months, the intralymphatic pressure steadily increases.
Eventually, that sheer pressure damages the vessel walls and blows out the valves,
resulting in severe fibrosis and a massive protein leak into the surrounding tissues. That leaked high-protein fluid significantly increases the interstitial oncotic pressure, which then pulls even more water out of the blood vessels and into the tissue. It creates a vicious cycle.
Low-volume insufficiency, on the other hand, is a physical roadblock. The system's actual transport capacity is physically reduced and cannot even deal with normal baseline quantities of lymph.
Which is the classic presentation you see after a surgical intervention, radiation therapy, or a parasitic infection that physically blocks the vessels.
Which brings us directly into how we classify the underlying etiologies. We divide the disease into primary and secondary lymphedema. Primary being a developmental abnormality.
Usually an inherent issue with the lymph vessels themselves, or in rarer cases, fibrosis or complete agenesis of the lymph nodes.
The key here is that the abnormalities are present at birth, even if they don't show up clinically until much later in the patient's life.
And for the boards, you must classify primary lymphedema strictly by the age of symptom onset into 3 distinct categories:
congenita, praecox, and tarda.
Right. Let's start with congenita. This is the earliest presentation, appearing at birth or within the first 2 years of life.
It accounts for about 10% of all primary cases and primarily affects the lower limbs, 3 times more common in females.
The crucial genetic association to remember for congenita is a mutation in the VEGFR3 gene.
When this specific presentation is familial, it is referred to clinically as non-Milroy syndrome.
But if congenita is the rare presentation we see in the nursery, lymphedema precox is the massive spike we see later on.
Precox accounts for a massive 80% of all primary lymphedema cases.
The onset is typically noticed between 2 and 35 years of age, often coinciding right around puberty. And the demographics here are striking. It is up to 10 times more common in females than in males.
That massive demographic skew strongly suggests that estrogen plays a significant role in the pathogenesis.
Clinically, it's usually unilateral, and it presents more often in the left leg than the right.
And when precox is familial, you will see it referred to on the exam as Meigs disease.
Then you have the late onset category, lymphedema tarda,
which only becomes apparent after the age of 35. It accounts for the remaining 10% of primary cases.
What's really interesting diagnostically is that while congenita and precox typically demonstrate hypoplasia or aplasia of the vessels on imaging,
tarda typically presents with hyperplasia of the lymphatic vessels.
Precisely. Moving away from the developmental causes, we have secondary lymphedema, which is acquired.
The classic mnemonic to rely on for the exam is the 5 I's. Let's run through them.
Number 1, invasion. This refers to primary or secondary tumors physically compressing or blocking the lymphatic system.
Number 2 is infection. This is a massive global factor. Worldwide, the most common cause of secondary lymphedema is actually filariasis.
Caused by the Wuchereria bancrofti parasite. Transmitted by mosquitoes, it physically obstructs the lymphatics, leading to the massive swelling known as elephantiasis.
Number 3 is inflammation. Severe localized trauma from things like snake bites, insect bites, or severe deep burns that scar the superficial layer.
Number 4 is irradiation. Radiation causes dense soft tissue fibrosis that strangles the delicate lymphatic collectors.
And finally, number 5, iatrogenic causes.
These are incredibly important for surgical residents. While filariasis is the leading cause globally, iatrogenic injury is the single most common cause of secondary lymphedema in the Western world.
Specifically, lymph node dissection for malignancy. Classic examples being axillary clearance for breast cancer or inguinal clearance for melanoma.
Even procedures like varicose vein stripping can inadvertently damage the superficial lymphatic collectors and cause an iatrogenic low-volume insufficiency.
Okay, so we know the etiologies. How do we clinically stage this disease according to the International Society of Lymphology, and what are the classic diagnostic pitfalls?
The ISL provides a progressive clinical staging scale from stage 0 to stage 3. Stage 0 is the subclinical or latent stage.
So the lymph transport capacity is demonstrably impaired, but the swelling isn't clinically evident yet.
Right. A patient can exist in stage 0 for months or even years following a lymph node dissection. Stage 1 is the early fluid accumulation stage, and crucially, it is reversible.
You see soft, pitting edema that actually subsides when the patient elevates the limb.
And there are no secondary soft tissue fibrotic changes yet. But if left untreated, it progresses to stage 2, which is the spontaneously irreversible stage.
This is where the protein accumulation really starts causing damage. You start seeing significant lymphostatic fibrosis and a physical hardening of the tissues.
Because of that fibrosis, the edema becomes non-pitting, and the swelling no longer reduces significantly with limb elevation.
This is also the stage where patients start suffering from frequent secondary soft tissue infections like cellulitis, which only accelerates the scarring.
Finally, you reach stage 3, which is lymphostatic elephantiasis.
Yeah.
Extreme volume increase, profound skin thickening, hyperpigmentation, deep skin folds.
Massive fat deposits, and the development of superficial papillomas.
Within any of those stages, objective volume assessment is a critical part of the workup. You are looking for a volume discrepancy between the affected limb and the normal limb.
Diagnostically speaking, the condition is officially confirmed if the affected limb volume is more than 10% greater than the normal healthy limb.
Clinicians can measure this via serial photography, basic circumferential tape measurements, water displacement, or modern methods like 3D cameras and pyrometry.
Alongside volume measurements, there are specific physical exam findings you have to master, the most famous being Stemmer's sign.
To test for Stemmer's sign, you attempt to pinch and lift a dorsal fold of skin at the base of the second toe, or the middle finger if you're examining an upper limb.
In a normal patient, you can easily pinch and lift that skin. But if the tissue is too thickened and fibrotic to pinch, Stemmer's sign is considered positive.
The major exam pitfall here involves the predictive value of the test. A positive Stemmer's sign is considered highly accurate for diagnosing extremity lymphedema.
However, a negative Stemmer's sign does not exclude lymphedema. Early-stage patients might still have pliable skin at the base of the digits, despite having lymphatic insufficiency proximally.
Another clinical challenge is differentiating true lymphedema from lipodema. Lipoedema is technically a lipodystrophy, a pathological accumulation of adipose tissue, rather than a fluid management failure.
The classic clinical differentiator is the anatomical distribution. Lipodema almost always stops abruptly at the ankles. It does not involve the feet.
Lymphedema, on the other hand, typically involves the entire extremity, crucially including the swelling of the foot itself.
As we discuss the clinical progression, we absolutely must highlight the worst-case scenario. Residents need to be hyper-aware of Stewart-Treves syndrome.
This is the malignant transformation of chronically lymphoedematous tissue into an aggressively invasive angiosarcoma.
It classically occurs in an upper limb following a mastectomy and axillary lymph node dissection for breast cancer.
It typically presents as purplish, bruise-like nodules on a chronically swollen arm. It occurs in roughly 10% of severely affected patients who have had the disease for over 10 years.
And the clinical reality of this complication is catastrophic. The 5-year survival rate following a lymphangiosarcoma diagnosis in these patients is incredibly dismal, sitting at less than 10%.
Because the long-term stakes are so high, accurate investigation and early aggressive non-surgical management are paramount.
So what are the gold standard imaging modalities, and what conservative management strategies must we exhaust before we even think about operating?
Well, historically, clinicians used direct lymphangiography, cannulating a lymph trunk and injecting patent blue dye along with an oily radio-opaque contrast directly into the vessel.
But you will rarely, if ever, see this used in modern practice.
Right. It's overly invasive, and the thick, oily contrast can actually cause further damage to the delicate internal valves, worsening the baseline fibrosis.
It exacerbates the very disease you were trying to map. So the field has completely shifted to indirect methods. Lymphoscintigraphy has largely replaced the direct contrast method for functional assessment.
Injecting a radioactive tracer, most commonly labeled with technetium-99 meters, intradermally, a gamma camera maps the flow and shows the exact rate of uptake.
But the true modern workhorse, especially for surgical planning, is ICG lymphography.
Yes, indocyanine green. When injected intradermally, it binds tightly to the plasma proteins present in the lymph.
And its absorption and fluorescence spectrum happens to sit in the near-infrared range. So when you illuminate the surgical field with a near-infrared light source, the lymphatic vessels literally glow.
It's like running a black light over a neon pipeline. It provides dynamic, high-resolution images of the superficial lymphatic flow within minutes.
It is absolutely critical because it allows surgeons to map the precise location of functional lymphatics intraoperatively and immediately verify the patency of their anastomosis.
Even with all this incredible imaging technology, surgery is absolutely the last resort. You must exhaust conservative management first.
The unquestioned gold standard here is complex decongestive physiotherapy.
Consisting of manual lymphatic drainage to physically redirect stagnant fluid, meticulous skin care, inelastic multi-layer compression bandaging, and remedial exercises.
Pharmacological management also plays a specific role. For early-stage filariasis, you utilize anthelmintic drugs, a combination of albendazole and diethylcarbamazine.
But if the patient already has severe established elephantiasis, merely treating the parasite will not resolve the structural lymphatic obstruction from the dead worms.
And discussing pharmacology brings us to a critical exam trap: diuretics.
Diuretics are absolutely contraindicated in the management of lymphedema. You must understand the exact physiological mechanism why.
Diuretics only remove the water from the interstitial space. They leave all of those high molecular weight proteins behind.
By stripping away the water, you inadvertently create a massive, dense concentration of interstitial protein. That concentrated protein sludge leads directly to rapid, severe tissue fibrosis.
And that incredibly high protein concentration exponentially increases the interstitial oncotic pressure, eventually pulling all of the fluid right back into the tissue the moment the diuretic wears off.
You actively worsen the underlying fibrotic destruction of the limb, and that underlying fibrotic destruction is exactly what dictates our surgical options.
For the less than 10% of patients who require surgery, what are the exact excisional and physiological procedures we need to know?
Excisional techniques are strictly reserved for advanced, severely fibrous disease, because debulking inherently removes any remaining functioning superficial lymphatics.
First is the Charles procedure, a radical circumferential excision of all the diseased subcutaneous tissue all the way down to the deep fascia, sparing only the sole of the foot.
The exposed deep fascia is covered with a split-skin graft. It carries a notoriously high complication rate: severe joint contracture, massive weeping papillomatosis.
Then you have the Hammond's procedure, a 4-stage operation involving near-total subcutaneous fat excision beneath long, thinned skin flaps.
And the Thompson procedure, which attempted to be partially physiological. The surgeon de-epithelializes the redundant edge of a skin flap and buries it deep into a subfascial muscle compartment,
Hoping the superficial lymphatics will drain into the deep muscular system, in modern practice, we also utilize liposuction.
Circumferential liposuction is excellent for removing excess fat from adipocyte proliferation, but the patient is entirely dependent on permanent, lifelong compression garments.
Which is why the field is heavily focused on physiological techniques designed to actually restore or improve lymphatic drainage.
The two main ones for the boards are lymphatic covenous shunts, or LVA, and vascularized lymph node transfer.
LVA involves anastomosing functional superficial lymphatic collectors directly to adjacent subdermal venules.
requiring supremicrosurgery techniques for vessels around zero point 0.3 millimeters. The non-negotiable prerequisite is that the patient must have intact, patent distal lymphatics capable of pushing fluid toward the anastomosis.
And for patients without patent local lymphatics, vascularized lymph node transfer, or VLNT, harvesting healthy vascularized lymph nodes and transferring them as a free flap to the affected limb.
The nodes act as an active suction pump, pulling fluid out of the interstitium.
But the truly brilliant part is that these nodes actively stimulate lymphangiogenesis.
Yes, by producing high local concentrations of vascular endothelial growth factor, specifically VEGFC.
For the exam, there is an elegant combination procedure used in breast reconstruction, incorporating superficial inguinal lymph nodes into a standard-free DIUP flap.
The abdominal tissue reconstructs the breast mound while the groin nodes are placed in the scarred axilla. The surgeon performs a second microvascular anastomosis, utilizing the superficial inferior epigastric artery system, the SIE system, directly to the thoracodorsal vessels.
That perfectly bridges the complex anatomy with the cutting-edge surgical solutions. Thank you for thoroughly breaking down the embryology, pathophysiology, imaging, and surgical masterclass.
It was a pleasure to synthesize all of this, but before we finish, I want to leave you with one final anatomical concept to think about.
Let's hear it.
We talked extensively about how lymphedema is strictly limited to the suprafascial tissues, the skin, and the fat. Why doesn't the skeletal muscle itself ever swell with that dense, high-protein fluid?
Why does it only happen superficial to the deep fascia?
Because the constant mechanical pumping action of skeletal muscle contracting during daily movement entirely prevents lymphedema from ever occurring within the muscle tissue itself. That subfacial environment is constantly squeezing fluid forward. It is a perfect reminder of the absolute power of physiological movement in maintaining fluid homeostasis.
What an incredible insight to end on. The mechanics of the human body really are amazing. If you are listening and have a question about the complex pathophysiology we covered today, or if you want to share a specific topic you'd like us to tackle next, please leave a comment or a question below. Keep studying hard, trust your preparation, and we will see you on the next deep dive.